Hello, and a good day to everyone. My name is C.D. Mamaril, and on behalf of the Systems for Action National Coordinating Center, I'd like to welcome everyone to today's Research in Progress webinar on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. Before we get started, we would like to first acknowledge the funding and support of the Robert Wood Johnson Foundation. Systems for Action is a national program office of the Robert Wood Johnson Foundation and a collaborative effort of the Center for Public Health Systems and Services Research in the College of Public Health and the Center for Poverty Research in the Gatton College of Business and Economics, administered by the University of Kentucky, Lexington, Kentucky. So we have a great webinar topic with us today, which is testing a shared decision-making model for health and social service delivery in East Harlem. If it's your first time to join us in one of these Research in Progress webinar series, I will first introduce our presenters and our commentary speaker for today's webinar. And after their presentation and commentary, we open the webinar to questions from the audience. So we would like to encourage everyone who are listening in or participating in this webinar that at any moment or any time during the presentation, if you have questions about the presentation, please do type in your questions in the chat box, I think that is found in the lower left-hand corner of your screen. So to get started, I will introduce our presenter, starting with Dr. Carl Letamendi, who is Director of Evaluation at the Health Department Center for Health Equity and Principal Investigator of the study. Carl is responsible for evaluation of the Health Department's neighborhood health action centers, as well as development and grant project support. He earned his bachelor's in business management, an MBA in finance, and a PhD in social science with an emphasis in conflict analysis and resolution. Carl has experience in program design and implementation, mentoring, and curriculum development. And prior to joining the Health Department, Carl served as a fellow at NIH's National Institute on Drug Abuse and at the U.S. Department of Agriculture's Office of Civil Rights, Diversity, and Inclusion in Washington, D.C. Carl also has nearly a decade of combined experience in higher education, which includes several teaching appointments, course design, and student counseling. Our other presenter is Rachel Dannefer, is the Director of Research and Evaluation for the Harlem Neighborhood Health Action Centers at the New York City Health Department. Rachel has spent close to a decade leading evaluation and research initiatives with a focus on neighborhood-based work. As Director of Research and Evaluation in Harlem, she oversees local research and evaluation efforts, including evaluation of the East Harlem's Neighborhood Health Action Center model. Rachel has a Master of Public Health and a Master of International Affairs from Columbia University. We also do like to mention, as part of their team also, we have Dr. Jennifer Pierre, who is co-PI of the study, and Luke Slater, who is Assistant Director for the PEACH study. Our commentator or commentary speaker for today will be Padmar John, who is manager of the East and Central Harlem Neighborhood Health Action Centers, where he has overseen the launch and operationalization of the Action Center in East Harlem. In this role, Padmar works with partner organizations and focuses on building community through collaboration, investment, and equity. Previously, Padmar served as the Executive Director of the George and Evanelle Barbie Family Health Center, and he has served in the Health Department's division of the Office of Emergency Preparedness and Response to improve healthcare facilities' abilities to respond to and recover from emergencies. Padmar has been a resident of Harlem since 1989 and received a master's from the New School in Health Services Management and Policy. So with that, I'd like to turn it over to you, Carl and Rachel.
Thank you so much for that wonderful introduction, and also thanks to everyone joining us this afternoon for our Research in Progress webinar. My name is Carl Letamendi, and I'm joined today by my colleague, Rachel Dannefer. We both represent the New York City Department of Health and Mental Hygiene Center for Health Equity. We'll open this presentation by discussing the purpose of our study, its connection to the Culture of Health framework, provide a little bit of background on the state of health in East Harlem, followed by discussing some of the causes of inequities, the Health Department's Neighborhood Health Action Center initiative, and then share the status of our study and what progress we anticipate making over the next couple of months. Towards the end of the presentation, we'll introduce you to Padmar, who's the manager of the Harlem Neighborhood Health Action Center and will be our commentary speaker this afternoon, and then we'll wrap up with some Q&A. So to start, I'd like to say that we actually have a nickname for our study, and now we have a peach in the Big Apple. The Partnerships to Encourage Actionable Cultures of Health study, which we refer to as PEACH, is a mixed method study which allows us to provide evidence on how aligning a city health department with cross-sector community stakeholders under a place-based model can improve health and reduce inequities across neighborhoods. At the epicenter of our study is the East Harlem Neighborhood Health Action Center, which is one of a few action centers we have across the city. The goal of our study is to evaluate the impact of this place-based cross-sector collaboration on the neighborhood. And aside from determining the impact using a mixture of qualitative and quantitative research, we also describe how a similar model can be replicated not just in New York City, but also in cities across the country. We recognize that oftentimes when we design studies or develop models, we oftentimes create them with our own stakeholders in mind, so those around in our circles or our environments. But with PEACH, what we really want to do is share strategies and our experiences, both positive and negative, so that even cities that are different than ours can work towards fostering a cross-sector collaboration. Even within a state, there could be differences in what two cities could look like. There could be geographic differences, there's rural versus urban environments, and there's also differences in even what transportation looks like between cities, and also political and socioeconomic differences as well. Once we get to the point when we're ready to share our experiences, we do intend to keep these differences across cities in mind, so we can provide tips on how to mitigate what could be some potential barriers to collaboration as well. I'd like to take a moment and recognize the Robert Wood Johnson Foundation for both their financial support and also for stepping in and defining the elements that make up a culture of health and how those elements result in improved population health and health equity. I'd also like to thank the University of Kentucky College of Public Health for their awesome coordinating support. They've really done a phenomenal job of bringing folks together to exchange ideas and ensure that this is a collaborative process. And also the Fund for Public Health in New York City, which is the nonprofit arm of the Health Department and the recipient of the award on behalf of the Department of Health. Now, when we first came across the Culture of Health Action Framework, the four action areas and how they achieve equity together, there was one action area that stood out to us, and that was number 2, fostering cross-sector collaboration to improve well-being. It's not necessarily to say that we're not touching on integrating health systems and services or creating healthier and equitable communities or ensuring that health is a shared value, but that second action area really spoke to the intentions behind co-locating partners within our neighborhood health action centers to begin with. So we decided to move forward with the call for applications for the 2-year study, and here we are. But when it comes to this study, there's many things that are going to be deliverables. We're going to have survey results, interview findings, data points, tips, insights, lessons learned. But one thing that we're also committed to doing is contributing to the evidence to the Culture of Health Action Framework overall. Last month, Robert Wood Johnson Foundation hosted a knowledge sharing conference in Arizona that was very inspirational, and it really made me take a good look at this Culture of Health Action Framework and made me wonder, is it possible that any one entity, community-based organization, or a local health department can achieve all action areas and create a culture of health? Perhaps, but maybe not. Maybe it takes more than that. In order to make this successful, I think we do have to approach this as a collaboration that transcends the walls of our offices. And I'm sure I can talk about this on and on for hours, but that might have to be a separate webinar, I think. And the research team for our PEACH study was already introduced. We have myself, Carl, on the upper left, and then we have Dr. Jennifer Pierre, Rachel Dannefer, and Luke Slater. And the 4 of us work very closely on the study and have taken on a few roles in the project to make sure that it's successful. Now, for those of you who aren't familiar with New York City, it's basically made up of 5 boroughs or counties which make up New York City, and I'll name the boroughs: Staten Island, Brooklyn, Queens, Manhattan, and the Bronx. So when you come visit, for those of you who are from out of state and you go to Times Square, you take a picture with Spider-Man in Central Park and you see tall buildings, that's Manhattan. For the most part, the lower portion of Manhattan. Manhattan is made up of many neighborhoods, and one of those neighborhoods is East Harlem, which is illustrated here by this orange marker. By the way, this information and what I'll share in the next couple of slides comes from these fantastic reports that the health department produces periodically, which are called community health profiles. They're basically reports of each community district in the city and how the district performs across several indicators, which speaks to neighborhood conditions, social and economic conditions, and also health outcomes. It's neat, and if your health department, your institute or organization is interested about thinking about replicating something like this, I encourage you to check out our community health profiles, which can be found at nyc.gov/health, and then click on data, and then publications, and it'll be the first thing you see on the left-hand side. Now, as far as East Harlem goes, there's a little over 123,000 in the neighborhood in a city of about 8.5 million. And in case you were wondering, we are the most populated city in the country. About half of East Harlem residents identify as Hispanic, 31% are Black, 12% white, and 6% Asian. The life expectancy in East Harlem is about 76 years. And in many other major cities across the country, and reflecting on some of the places where I've lived, which is South Florida, Washington, D.C., and now New York, usually you'll anticipate seeing a gradient across cities. So what I mean by that gradient is that perhaps you start off in any neighborhood on a map, and as you move across the map in any direction, you'll see gradual changes in indicators. But I want to highlight something in particular that should be mentioned, and it's that one of Harlem's neighborhoods is a neighborhood called the Upper East Side, which I'll use these handy tools here for you to see. And it's that one that I just circled. Now, when you look at this map and you see that these two adjacent neighborhoods, when you see the two adjacent neighborhoods, you start to see that at one point you can literally cross the street and there's an almost entire decade difference in life expectancy. So when we see that, you start to wonder, why is this? How does this happen? There's a slide in the presentation where I'll briefly talk about some of the root causes of the disparities that we see in New York City today. The one that really stands out is structural racism and racist policies, which have resulted in some of the health outcomes we see today. It's also things that transcend one generation. It's transgenerational systemic racism. It's policies which have inhibited transgenerational wealth, drug policies, redlining, the GI Bill. These are just some of the historical acts that have shaped the way that our cities appear today and which can help to describe the health outcomes that we see in New York. These data also come from our community health profiles. You'll see that East Harlem's figures are in orange. In green, you'll see the best performing neighborhood in the city. In purple is the county or the borough average, and citywide in baby blue. For self-reported health, you'll see that 70% of East Harlem residents have rated their health as either excellent, very good, or good, which is below East Harlem's neighbor, the one that I just circled on the previous slide, the Upper East Side. The borough, it's also below the borough and below the city. As we look across indicators, we start to see similar patterns. Infant mortality rates at East Harlem are 6 per 1,000 live births. We have 301 premature deaths per 100,000 in the population. High rates of adult hospitalizations for asthma and diabetes in comparison to the borough and city, and also high rates of psychiatric and non-fatal assault-related hospitalizations compared to the borough and to the city. Now, I mentioned this a couple of slides ago, but the disparities that we see make us wonder, what is it about East Harlem that results in these health disparities and negative health outcomes? Well, as a health department, we understand that the root causes of inequities are as a result of policies that created multiple systems of unbalanced power and privilege, historical practices of exclusion, and discrimination across the life course. As a result of these systems, we now have geographic concentrations of poverty and hypersegregation, and these are all relevant conversations to elevate across health departments and other public health entities, because contemporary public health practice should recognize that these factors have perpetuated the health outcomes that we see in our neighborhoods. And the image here might be a familiar one. It's a great illustration of how, as a field, we've started to transition from the concept of equality and turning more towards equity. We understand that these terms can't really be used interchangeably. They don't necessarily mean the same thing, and the approaches to achieving both are different. So I think if we want to collectively take steps towards achieving optimal health for our residents and the people we serve, we have to address inequities. It's not comfortable and it's not easy, but I really do think that getting uncomfortable and taking the work on is a prerequisite towards achieving equity. In response to the inequities that we see, the Health Department Center for Health Equity has implemented a place-based approach. A neighborhood's health results from historical, social, and physical forces that have shaped it. Some of our neighborhoods have been deprived of resources and attention, so in order to right the injustice, we have neighborhood offices in areas that bear the highest disease burden, and East Harlem is one of those neighborhoods. The vision of the Health Department Center for Health Equity, which is under the leadership of our Deputy Commissioner, Dr. Letamendi, and our Commissioner of Health, Dr. Mary Bassett, is that every New Yorker lives in a thriving neighborhood where resources work well and systems are equitable in order to nurture and sustain healthy individuals and communities. Our mission is to strengthen and amplify the Health Department's work to eliminate health inequities, which are rooted in historical and contemporary injustices and discrimination, including racism. And now I would like to hand over the figurative mic to my colleague Rachel Dannefer, who will lead us through some specifics about the work of the action centers and also the progress of our PEACH study. Rachel?
Okay, great. So first, I wanted to start by giving a brief history, and share that the Health Department's history of using neighborhood-based approaches actually dates back to almost 100 years ago, when the Health Department established a pilot project in East Harlem, and you can see a photo of the building there on the left, which co-located health services, welfare agencies, and community-based organizations to improve community health. This pilot project was successful, and the movement expanded to include 30 district health buildings across the city. And then in 2003, in an effort to bring back the focus to neighborhoods, the Health Department established district public health offices in the South Bronx, East and Central Harlem, and North and Central Brooklyn. And this was really an effort to target public health programming and resources in New York City neighborhoods with the highest rates of illness and premature death. And then in 2017, building on this work, the Health Department established neighborhood health action centers. So in addition to continuing the work of the district public health offices, launching these action centers has meant revitalizing city buildings to make space more available to the community, and co-locating health services, community-based organizations, and other service providers under one roof, sort of taking a new approach to the district health centers of 100 years ago. And if you look at the photo on the right, that's actually the East Harlem Neighborhood Health Action Center today, which is the same photo, same building that you see in the photo on the left. So we wanted to show you the action center locations, and Carl kind of talked you through the makeup of New York City. So we have 5 counties, which we call boroughs, Bronx, Manhattan, Queens, Brooklyn, and Staten Island, which you can see there. And then you can see the current action center locations represented by the black stars on the map to the right. The catchment area of the Bronx Neighborhood Health Action Center is in blue, Harlem is in red, and Brooklyn is in green. And then the crosshatches that you see cover the more local action center neighborhoods within these larger catchment areas. So these are community districts in which the buildings are located and are the more localized areas in which we focus. And the Health Department does plan to open at least 4 additional action centers within these catchment areas in the coming years, but these 3 have been the first to open. And then as we've been talking about, PEACH is really focused on the work of the Harlem Neighborhood Health Action Center, so the one in red. So the Action Center model is based on 3 key strategies. The first strategy is co-location and referrals. This involves revitalizing underused buildings to house co-located partners and services, and also implementing a robust referral system to better serve the community and to identify gaps in services that are available. And we're doing this through a system called NowPal, which is an electronic referral system that provides a resource directory, allows for bidirectional referrals, and also referrals tracking. And I'll talk more about NowPal later. Another strategy is innovation in programs and policies by using data and evidence-informed practice, as well as community expertise to address root causes of poor health. And then finally, collective action and impact involves identifying and elevating systems-level barriers and policy opportunities based on what we're learning and finding ways to bring groups together to address these issues. So to get a little more specific about what the Action Centers offer, as I've talked about, one key piece in the orange there is offering co-located services to provide direct clinical and social services to residents. The Action Centers also have navigators and referral specialists. These are staff who specialize in helping residents and getting them the services they need. Each Action Center also has a family wellness suite with a lactation lounge, a children's nook, and programming like parenting groups and childbirth education classes. The Action Centers also offer neighborhood convening spaces. So they have multi-purpose rooms for neighborhood partners and residents to use, and also space for physical activities and events. And finally, some Action Centers will feature teaching kitchens and gardens. So in East Harlem, there are currently 5 external partners located in the building, and I'll just talk through them briefly. So Concrete Safaris, you can see their logo on the top there. They offer youth programming around gardening and fitness. Public Health Solutions to the left provides SNAP and health insurance enrollment. IDMIC offers free identification cards for all New Yorkers. SMART, which stands for Sisterhood Mobilized for AIDS, HIV Research and Treatment, offers HIV programming and support, and also nutrition and cooking classes. And finally, the Association to Benefit Children, or ABC, offers mental health services for children and their families. We're also working on getting a clinical partner into the building, and that should be happening in the near future. So a number of health department programs are also part of the Action Center. We have a community health worker program through Harlem Health Advocacy Partners, listed over there in the blue. The East Harlem Asthma Center of Excellence offers asthma counseling for children and their families. And then we have several other programs and services offered through the Action Center. So the PEACH study is really to look at this model and is guided by 3 objectives. The first is to determine how aligning the City Health Department, clinical and non-clinical partners, and frontline staff in a collective governance structure within the Action Center builds a culture of health. The second is to determine whether the use of NowPal by Action Center stakeholders fosters a cross-sector collaboration to improve health and well-being. And NowPal is that referral system I mentioned earlier. And third is to evaluate the impact of the Action Center on the health of East Harlem. So all of our activities through PEACH will culminate, as Carl mentioned, in a final report that details how this alignment can be scaled up in New York City and replicated in other locations. We plan to use a range of qualitative and quantitative data sources to meet these objectives, and I'll talk about each of these in more detail, but just as an overview, we anticipate conducting Governance Council member interviews. So this is the group comprised of co-located and health department partners who are within the building and who meet monthly, and this is that governance structure that's talked about in our objectives. We also plan to conduct qualitative interviews with key staff at the Action Center. We'll use data generated through the NowPal system. We'll be surveying visitors to the Action Center. And finally, we will be using some monitoring and tracking data from the Action Center. So first I'll talk more about the Governance Council interviews. As I mentioned, the Governance Council includes representatives from each co-located partner, and we meet monthly. And here you can actually see a photo at our monthly Governance Council meeting. So this group supports coordination of services and planning at the building level, and is really a way to help all of the partners and the programs in the building work together. The purpose of the Governance Council is to promote transparency, support cohesion and collaboration, address building management issues, to ensure customer relations are of the highest possible standards, and also to respond to community needs, and to conduct strategic planning. So we actually conducted baseline qualitative interviews with Governance Council members about a year ago, prior to the launch of PEACH, but I wanted to share some of the themes that came out about anticipated benefits to being part of the Action Centers. So we interviewed around 10 representatives from our co-located partners and also from health department staff in the building. So one key theme that emerged was around collaboration and reach. Interviewees were excited about collaborating with Action Center staff and partners about being able to connect programs for collaborative opportunities, and also to be able to make referrals between partners and to share staff and resources. They also anticipated being able to increase their own capacity and reach through the Action Center and engage new community members. People interviewed were also really excited about the building. So for two of the partners who moved into the building, this was actually the first real office space they had ever had. So they were especially excited about the space. Partners were excited about the good location of the Action Center, and also about the idea of creating an attractive space with art displays and other ways to make the building engaging for residents. And finally, interviewees anticipated benefits in terms of community impact. They saw the Action Center as a way to fill service gaps in the community, to raise awareness about health issues and promote programs and services, and ultimately to improve health outcomes in the neighborhood. And right now we're getting ready as part of PEACH to launch another round of interviews with governance council members and just hear about their experiences with this co-location model and how it's been working. We're also planning to conduct qualitative interviews with key Action Center staff, including frontline staff who are at the center of the action and who know the flow of information, who are making referrals, and who can really see how this cross-sector approach is playing out on the ground. So this will include interviewing the navigator, and this person sits at the front of the building and is the first point of contact for people coming in. So they welcome visitors and orient them to the Action Center services. They also help to coordinate across partners and programs in the building. We will also interview the referral specialist. This person connects residents with service providers and is really an expert in making referrals and in using NowPal, and is actually leading implementation of NowPal across providers in the building. And finally, we'll interview health promoters. There are 3 health promoters at the Action Center in East Harlem. They're really out in the neighborhood promoting the Action Center, developing relationships with local organizations and also with local businesses and retailers in the neighborhood, and promoting programs to residents. So another key data source for PEACH will be NowPal. And as I mentioned previously, NowPal is a web-based resource directory and referral system that allows community members to find healthcare, social services, and public health programs while connecting the provider network to facilitate referrals. So NowPal is new for us, and we're still rolling it out. But at this point, every co-located partner at the Action Center has NowPal. We're also working to onboard local partners to use NowPal, and we're coordinating with 6 health systems in New York City that have also adopted NowPal. So core functions offered through NowPal are a comprehensive and regularly updated resource directory, the ability to do social needs screenings with residents, bidirectional referral management, the ability to create client-centered action plans with reminder tools, and also the ability to create dashboards for each organization. So right now, since, as I said, we're sort of early on in implementing NowPal, we're using it mainly as a resource directory. However, we'll eventually be able to use it with partners around the city to make referrals, which is something we're all really excited about. So there are a lot of benefits and opportunities with the data we'll have from NowPal. So we'll be able to use it to track the number of successful referrals made, to identify gaps in services by seeing what are the needs that we're unable to meet through current resources and services. We can also use the data we get through NowPal to conduct needs analysis and to understand needs around social determinants of health by looking at services for which we're making a large number of referrals. So we also plan to survey visitors this summer around their experiences in the Action Center. We'll be asking them about their perceptions of the physical space, about their experience with customer service, and just sort of their overall experience in the building, about the quality of care and services they've received through the Action Center, and the ability of the Action Center to meet their needs. We'll also talk to them about social cohesion and sort of understand how tied they feel to the East Harlem community. So another key data source will be monitoring and tracking data that we've been collecting, including the number of visitors to the Action Center. So in the time frame shown here, which goes from January 2017 to February of 2018, you can see our number of visitors each month during this time period, and we've had about almost 20,000 visitors to the Action Center during this time. And we just track this through a simple paper and pencil tracking system. So as we wait for NowPal to get rolled out, we've also been maintaining our own tracking of referrals. And since the start of last year, the Action Center has made more than 600 referrals. This is just referrals made by health department staff at the Action Center. It doesn't count those made by co-located partners. And as you can see, during this period, we made 261 referrals to programs within the health department, 270 to external programs, and 82 to co-located partners, with the top referral categories being for sexual health services, ESL classes, and getting a physical completed. So I'll wrap up with next steps for our PEACH work. So for the spring, as I mentioned, we're gearing up to do governance council interviews. We will also be getting door foot traffic counters. So these are sensors which will be installed in the doorways of the Action Center buildings to count the number of people coming into the buildings. We'll also be continuing to roll out NowPal. This summer we plan to do the key East Harlem key players interviews I mentioned with East Harlem staff at the Action Centers, and also to do surveys with visitors to the Action Centers. And then we'll be working to pull together administrative data to look at health indicators to help us evaluate the impact of the Action Center on the East Harlem community. So I will leave it there. I think we'll have time in a few minutes for questions, and you're also welcome to contact us with any questions after the webinar at the email addresses on this slide.
Thank you, Rachel. Thank you, Carl. And again, a reminder, we'd like to, if you have any questions, please do type them in the chat box so we can get to them. But before we do that, we'd like to first turn it over to our commentary speaker today, Padmore John. Padmore, you have the floor.
Yes, hi. Thank you very much to everyone that preceded me, and to all the sponsors that are making this possible. So just going to briefly go over some of the things that we had to go through in terms of getting the Action Center, as we call it, up and running. And I will start at the very beginning. So we pretty much started to get staff in place around May to August, to the end of the summer of 2016. And at the same time, we were working on facilitating and bringing into our co-located partners into the building. So as Carla mentioned earlier, there was an RFP that was put out probably approximately a year before. And the co-located partners, and these are various community-based organizations, providing a variety of services from direct healthcare delivery to social services and nutritional services. And they responded, and ultimately 5 of them were selected. And for them to come in, there was an agreement that was to be signed, as well as various documentation, insurance, and all the likes. So we had to basically work with our partners in being able to package all of that information. We were working very closely with other divisions within the Department of Health, from operations to legal to finance, to ensure that everyone that is coming in comes in the correct way. So because of that, various programs that were a little bit more nimble and able to get all the documentation together came in first. So by the summer of 2016, we had our first programs that were coming in. That was Smart University. Shortly thereafter was Concrete Safari. And then towards the end of the year, all of our 4 programs initially had come in. Around that time, with all of our staff was in place as well. And so towards September 2016 is when we officially started taking and collecting data. And that data initially was just the amount of people that are coming into the building, some of the services that they're coming in for, and the referrals that we were making, whether between ourselves internal to the building, or between other organizations that are external to the Action Center. After that, so as Rachel mentioned, the building that we are located in was built sometimes in the 1930s, and it has been under the control of the Department of Health for all that time. And throughout that time, from the 1930s until now, its use went up and down. During the 40s and 50s, there was a significant amount of investment being made at the Department of Health to maintain and keep up the building. During the 60s and 70s, New York City went through a fiscal crisis, and many of the buildings within the Department of Health that were not central to some of the work that was being done, they lost investment, and there was some deterioration in the building. So one of the first things that we were doing with our partners was to see how we might be able to beautify the building. At the same time, the Department of Health, through operations and other divisions, was also working on making improvements to the structural component of the building as well. So those initial meetings, what we were calling beautification meetings, kind of led to what Rachel defined as the Governance Council. As the organizations start to meet, part of the agreement, there was an agreement in their contracts that they were expected to give a certain amount of time towards participation within the Governance Council. But it wasn't until maybe the fall of 2016 that these Governance Council meetings actually got stood up in proper. But prior to that, during the late summer, we were operating under beautification mode to try and get the building looking a little bit better. And that had a great deal of impact in how we moved along in terms of developing some of the ideas that we were thinking of that became programs. So, for example, one of the things that we wanted to do was to put some art in the building. And because of the concept of everyone around the Governance Council agreeing that art was a great way to make the space look better, we actually developed an art program, an art therapy program, where we have a slated amount of artists that come in, they put their work up. It's part of what we're calling art therapy, as well as encouraging artwork within the building and arts as a means of addressing mental health abuse. So that, and I think that's kind of a rather large aspect of how a lot of the things occurred during the initial beginnings of setting up the Action Center. Many of the things that we saw were challenges, and we definitely were looking to address those challenges, and many of the ways that we were thinking of solutions for those challenges eventually became programs. And those programs are ongoing right now. Another one was basically how we could utilize the space that we had. As Rachel mentioned, we were unable to bring in our healthcare delivery partner, but we're still in the process of negotiating for another service provider. But in the meantime, we had some available space. That available space was to some extent going unutilized. While we have the designated permanent co-located partners, we were able to utilize the space as temporary, what we're calling pop-up for a space for community-based organizations. And that has kind of led to two things. One, it has strengthened the relationship with many of the organizations in our neighborhood, within our community, within our catchment area, by being able for us to allow them to utilize the space in that way, typically always free of charge, as they're providing either trainings or some sort of a service delivery to the community. And ultimately, they have been able to extend and expand their capacity to provide their services because of limitations in the space they had in their own buildings. So it will allow us to really grow on both ends and to strengthen our partnerships. And that was a very important aspect of many of the things that we are doing in the first year, was the growth of partnerships. As Rachel mentioned, our promoters go out and give information to the community about a lot of the activities and programs that we are doing within the Action Center. But part of their work is also to identify new businesses, new organizations, or organizations that we did not know of. Some even individuals that have a particular skill that may be somewhat, we term, a hidden treasure, and encourage them to come to the Action Center to see how they may be able to utilize the space at the Action Center to provide the service to the community. And those relationships begin with the promoters, and we encourage them to go out and do that with a very specific agenda of bringing in partners back into the Action Center. And from there, myself as a manager or coordinator work on building those partnerships with those particular organizations. And then right now we are in the process of we're still some structural changes that needs to be done. As mentioned earlier, there will be a kitchen within our building, and we're in the process of still developing that. We're still in the process of fixing up our multipurpose room, but we expect those to be completed within a year or two and to expand on the services that we're able to provide. The kitchen allows us to work to focus on workforce development as well, so that is something that we are actively working on. So right now we are in the programmatic development component of the Action Center. Many of this initially, as I mentioned earlier, was basically determining what are some of the issues, some of the challenges that the community is facing, and how we might be able to address them within the Action Center or support organizations that are doing some of the services for those particular issues. We had a challenge of one of the things that we have seen was a need for assistance in legal matters, especially in New York City, specifically in East Harlem. There's a lot of challenges with tenants being forced out by the landlords as they look to increase the rent and rehabilitate the apartments, increase the rent, and get as part of gentrification that's happening within the area. So we were able to work with HRA, which is Human Resources Administration of New York City, and they're providing support for access to free legal aid, and this is being done on a regular basis at the Action Center. And one of the final things that we are in the process of doing right now is building an advisory board to provide support and some as a sounding board for many of the activities, and even to give indications and directions of how the Action Center should be going. And this is in the process of being done right now. And one of the things that we did to accomplish that was to have significant amount of listening sessions, basically where we propose the idea to the community and solicit their feedback. And this was very successful in its initial goal. And it's a process that we are looking to develop and use constantly in terms of improving and enhancing our programming. So I will stop there and allow for any questions to all of us.
Thank you, Padmore. And we do have a lot of questions from our audience, but before we get to them, just quickly, will the research team like to sort of respond or add on to some of what Padmore mentioned or commented on? Carl, Rachel?
I think I'll just say I think that's a great kind of illustration of all of the kind of innovation and adaptation that's happening with this model as it gets rolled out, as we see new opportunities, as we see new needs in the community. I think that really kind of helps explain what it's like to operationalize this idea. And I see there are a lot of questions, so I think I'll just leave it at that.
All right. Sounds great. So yes, we do have about 15 minutes left in the webinar, so we'll try to get to as many of the questions as we can. We do apologize in advance if we don't get to. We will make sure to forward it to the research team. So let's get started with a question from Jason, and anyone from the research team or even Padmore can answer these questions. Jason asks, how was your experience implementing NowPal and merging this data with your agency's data system? Do the two talk to one another? And I'd like to add, sort of just speak briefly about sort of how the MapsCore data engine or, your partnership with MapsCore came about too as well.
So maybe I can speak to this a little bit. So right now, merging the data sources are conversations that are taking place. And the partners at the Action Centers are using NowPal for looking up resources, but they'll soon be able to start initiating those bidirectional referrals. So that's all part of the process of seeing how this unfolds over time as well. And it's definitely something that we've kept in mind too, to make sure that systems talk to one another. It's something that, whenever you're bringing in a new system, you want to make sure that you have that. And one of the great things of working with this particular vendor is that they've been very kind of like adaptive to the needs of the neighborhood health action centers, and they've done a lot of listening. And it's actually one of the recommendations that we anticipate putting forward is that when you come to the table and you're trying to bring in like a new system or maybe like a new vendor, to make sure that you bring your needs to the table. To make sure that you're really getting something that's holistic and that satisfies everything that you're looking for.
So I guess just to quickly follow up, you mentioned in the presentation that you have these population health management dashboards available for each of the partner organizations in the Action Center. Is that coming out of NowPal, or is that, do you eventually foresee something like an app for like the end user residents that they could use to as well?
Well, the partners do have their own dashboards where they're able to see the number of clients that they've referred out, and also to see how many successful referrals they've actually achieved. And they'll also have the opportunity to kind of like now in NowPal they call it a nudge, where it's kind of like a friendly reminder that's sent via email or text message, and it also provides the opportunity for engaging the clients through phone as well. So they have that's something that NowPal does provide, is those automated dashboards, so that the partners can keep track. And then the Action Center as a whole also has the ability to go in and pull reports, and it's a pretty holistic system.
So Lisette asked, do you have any data right now on how many of your referrals resulted in kept appointments?
Once we do have the ability to do those bidirectional referrals, because some partners are still being trained on certain elements, so the rollout is still taking place. Yes, we will eventually have data on which proportion of our referrals were actually successful, and by success we mean that the client actually went to the place where they were referred to. So we don't have those data now, but very soon we will start having that information.
Okay. Bao asks, is there a case manager or liaison person at the Action Center who tracks referrals and follow-throughs with referrals and follows up with the clients?
Yes, there is. So that's the role of the referral specialist. And even to some extent our navigator, both of them, although the referral specialist is much more in tune with some of the needs of clients, but they do follow up. Well, right now there is a potentiality to do that through NowPal, but right now it's being done with either folks that are coming back into the Action Center or just calls that are being made by referral specialists to the folks that they give the referral to.
Okay. Ruth asks, I'm wondering how the referral information flows into the EMR. The information be key to understanding the goodness of fit of the referral to the identified social determinant of health deficit and the referral's influence on health outcomes.
Yeah, so right now a lot of there's no integration between EMRs and NowPal. There are some health facilities that have received NowPal, but they are still somewhat skeptical in making that integration just because of HIPAA laws and ensuring patient privacy. I think as it unfolds a little bit more and they're a little bit more comfortable, and there's a potential for that to occur, but it's not happening right now.
Okay. So again, we just like to encourage everyone that if you have questions, just please type them in the chat box, the lower left-hand corner of your screen. John asks, could you discuss the services available to elderly and disabled facilitated by the Action Center? They tend to have high need for home and community-based services, particularly those with chronic disease.
Sure. So one of our partners, Public Health Solutions, they actually does SNAP enrollment and for the elderly, as well as Medicaid enrollment for the elderly and the disabled. one of the things that we are doing right now also is working with some partners nearby that have provided a lot of focus on servicing elderly populations. So we are partnering with them whether or not we can provide some services at the Action Center, but also be able to allow some of these partners to be able to conduct their services at the Action Center. So either way, that's something that Rachel, I mentioned an initial survey, and that's one of the things that we look at was some of the age groups, and we realized that we are not very well positioned to provide a lot of services to the elderly, so we are now developing some programming around that. We recently conducted, in one of our listening sessions that I mentioned in terms of the development of the advisory board, we also learned a great deal about a population that we didn't even know that that was growing in East Harlem, which is the Chinese-speaking population. And we also realized that many of that population are of the elderly. So we are in a process right now of developing some programs for that population.
And this is Rachel, I'll just add to that. We also have a program that operates out of the Action Center called Harlem Health Advocacy Partners, which I mentioned is a community health worker initiative. And it focuses on residents in who live in public housing developments in East and Central Harlem. And while it doesn't explicitly kind of target seniors, it certainly does attract a lot of seniors and has kind of tailored services for people who have hypertension, diabetes, asthma, and other chronic diseases. So I think that program is a strong link with seniors in the community.
Yeah.
All right. I'm going to try to tie in some of these questions. They might be related to each other. So one is from Laura, who asked, at the end of the Peach Initiative, how will the success of the program be measured? Kelly asked, how do you see this being sustainable in terms of funding for the long term? And in relation, she also asked, who pays the salaries of the folks who work in the Action Center?
Okay, so I guess I'll start with the third one because this is funded by the city, so city tax levy money. That was recently, I think in 2016, there was new funding that was allocated specifically for staff at the Action Centers, and it is being re-upped. So at least for the 3 initial Action Centers is being paid by tax money from the City of New York. The intent is to open 4 others, as Rachel had mentioned, and those also will be funded by tax funding. There was a recent declaration made by the current chair of the Health Committee of City Council that they're looking to even provide more financing for the opening of a few more of these Action Centers. So there is sustainability. One of the things that we are also working closely with our partners is not only for us, but for them to have access to external funding. So we've written a lot of support. We have done a couple of joint grant requests with some of our partners. So at least for us, to some extent, there's some sustainability and continuity with the tax money that's coming from the city. But we are also looking to enhance some of the services we provide through grant funding.
So I guess just to follow up with the team, Laura asked, at the end of the Peach Initiative, how do you think the success of the program will be measured?
Sure. So I'll contribute to that one. So Robert Wood Johnson has a couple of drivers that are packed into that second action area, which is fostering cross-sector collaboration to improve well-being. So since we're going to be contributing to the evidence, we know that we're successful when we can really sit back and reflect and see that we've added to the body of knowledge around how to build and maintain that cross-sector collaboration. So not just being able to capture like all of the things that work well and that have resulted in positive experiences for our visitors, but also elevating what doesn't work or what hasn't worked in our experience.
All right. So we've got 4 more questions. We'll try to pack it in with the remaining time. What is the time commitment for community partners in participating in the Governance Council? Katie asked, are there specific appointed representatives from each co-located entity, or does attendance shift from time to time?
So as long as organization is part of the Action Center, they're expected to participate in the Governance Council meetings. So typically we want a decision maker from that organization to be within that meeting, because there are certain decisions that will be made in there. And as long as definitely anyone can represent their organization, but as long as they're able to make make decisions within that meeting and be able to have their organization commit to those decisions.
So John asked, it sounds like the focus on making the space, I guess, is Action Center, inviting beautification artwork facilitated, getting the community and programs into the door, getting people to actually access needed services critical. Make sure this is discussed in the report for scaling up to other areas. So I guess he's making a recommendation. Dawn says, is there any measurement work being done on residents' health? Is the study attempting to show the residents' health outcomes improve as a result of your approach or your cross-sector alignment approach?
So I will say that there are, in terms of measurement work on residents' health, there are sort of a few key ways we can look at health at the neighborhood level. One is that the health department does an annual community health survey, and that's where a lot of the data that Carl presented at the beginning comes from. And that's something that, with that, we can actually drill down to the community district level. And then another source that we'll be monitoring to look at residents' health is hospitalization and emergency department visit data for the city of New York. And there again, we can actually look at residents' addresses in the data source. And I think that is something in the long term we're certainly monitoring with this approach and looking to see if we're able to change this. On the other hand, we recognize this is something that takes a long time and probably we wouldn't see a dramatic change in a short time period in this one. Carl, I'll let you add anything you want.
Yeah, I just want to address John's comment, and I really appreciate, yes, definitely it's crucial to make sure that we're taking a look at the community as well, and it's actually also one of the action areas in the Robert Wood Johnson Culture of Action Framework, and one of those measures includes sense of community as well. So then you got that on the one hand, but then you also want to make sure that when it comes to the partners that are delivering the services, that you're able to listen and identify what it is that their needs are. And if you do have the capacity to be able to provide something to that community-based organization, then by all means, they're really helping to try to encourage, a positive and cohesive environment in the community.
Yeah, and I'll just add, I appreciated that comment as well, because I think part of this approach is really trying to change the nature of the relationship we have with residents and with community partners, and really create a space that, when you walk in, you don't feel like you're being processed by city government, but rather it's a community space, it's a welcoming space, and is there to support the health of the community.
And we have one last question, time for one last question from Maria. Is there any special notation in your data or even knowledge of serving clients that are recent returnees from New York State prisons or Rikers? Have you reached out to those organizations to connect they're about to be released individuals who might be moving back to East Harlem? Don't ask when will the report be available. So I guess if you can tie in these last two questions.
Yeah, well, we haven't. We've just started a significant amount of programming around mass incarceration in general. We have reached out to. We're working with Hunter College, Stillman School of Social Work. One of the things that they do is there's a community navigator program that connects recent reentry citizens to various programs, and we are connecting with them to allow them to have access to various services that we provide, and also to be able to connect to other services that they may need. So that we have created a partnership with that. We actually tonight we have an event going on where we are screening a film and encouraging panelists that are speaking about bail, speaking about jail reform in the incarceration system. As many of you know, Rikers is slated to be closed, so we have an idea of what are some of the expected outcomes from that closure, how will it affect community, and what type of mental health needs that reentry citizens will be having. So we're in the process of being able to facilitate and provide services for that population. In terms of when the report comes out?
Sure. We expect to have kind of like a mid-study report towards the end of this year, and then the final report somewhere towards like November of 2019.
All right. So with that, we would like to thank you so much, Carl, Rachel, Jennifer, Luke, and Padmore. Excellent presentation, and we look forward more to hearing from your work as it moves forward. And we'd like to thank everyone, too, for those great questions. And we do invite you once again to today's webinar to let you know that today's webinar will be available for download from the Systems for Action website. And we also look forward to seeing you and joining us in our future Research in Progress webinars that you could look up also at the Systems for Action website. So once again, thank you, everyone, for joining us today.